Welcome to I'll Have You Know, a podcast from Rice Business. This episode is part of our Up Next series, where faculty, researchers, and alumni weigh in on the trends currently shaping the world of business. On this episode of I'll Have You Know, we dive deep into the innovative world of designing, managing, and optimizing an industry impacting all of us. Rice Business professor Tolga Tezcan has poured his life's work into researching healthcare systems around the globe. Originally from Turkey, Dr. Tezcan has served on faculties at London Business School, the University of Illinois, and the University of Rochester, before making his way to Rice, where he was given an opportunity he simply couldn't pass up. We talk about his latest research, the biggest barriers for adopting operational efficiencies in healthcare, the greatest opportunities he sees for innovation, and how the Houston Medical Center is leading the way to the future. Hello, everyone. I'm your host, Maya Pomroy. Our guest today is Professor Tolga Tezcan, Professor of Operations Management, who teaches courses in business analytics, data mining, and of course, ops management. Your current research explores really fascinating things, including innovative ways of designing and managing healthcare delivery systems. Really looking forward to talking about that and its efficiencies and inefficiencies and bottlenecks and all of those things that are crucial to economics, really. Thank you so much for joining us today.
Thanks for having me, Maya. I'm glad to be here.
So for somebody that doesn't understand operations management, could you please describe what the study of operations management is for those that really don't know?
Excellent. For those of you who are really interested, I think they should take my operations course, or they should
Agreed.
take a mitzvah. It's very difficult to summarize in 2 minutes, but that's a great question. So, I've been teaching in business school since 2010, so it's been a while, and I've been teaching operations, primarily operations, although I teach some business analytics as well. And it took a while for me to answer that question because nobody asked that question to a marketing professor or a finance professor or an accounting professor. That question is never asked. It's always
clear cut.
That's what is operations or OB, Yeah. It's always us. So it took me a while. And the shortest answer I could tell you is think about a business from a strategic point of view. Let's look at it at the macro level. What they do can be answered in 3 questions. Who are their customers? What do they sell? From a differentiated marketing, from a competitive advantage point of view. Mm-hmm. And finally, how do they do it? And who and what, this is marketing, OB and all that, or technology even sometimes if you talk to think about more technology companies. And how question is what operations answers predominantly. For example, I always give this example to students in class. How do you think Walmart became Walmart, but not some other company? And most people say, well, Walmart is so big, they have the upper hand in negotiations.
Not at the beginning.
Exactly. Do you know where Walmart started from? It was in a small town in Arkansas with a single store. And we go into what their operations enabled them and increase their profit margins, which allow them to grow.
The innovation.
Yeah. But that was all about, Walmart doesn't sell innovative products.
Right.
It doesn't serve to a customer base that never went to a supermarket before. They specialize in certain things, but again, everybody could have sold them. They didn't innovate that. What they innovated was change the question how you would take these items to their stores. And same thing with Amazon when it started. Again, the way they did it was by selling all these books online, they managed their inventory a lot better than anybody could. So that was their innovation.
It was the efficiency.
Again, it wasn't that, nobody could sell those books. Those books you can buy from anywhere, from all the publishers and sell it yourself. But they found a way to do it in a different way. So again, whenever I teach the operations course towards the end, when I'm finishing the course, I say, look, if you don't remember anything from this course 5 years down the road, operations answers the how question for a business strategy point of view. That's how I would describe it.
It's also fascinating because operations, if you don't have that down, doesn't matter how great you are, you're going to fail.
Again, these questions are interrelated.
Yes.
So you can have the best answers in who to what, but as long as you don't have the how question figured out, obviously you're not going to be able to deliver it. So in a way, operations delivers your competitive target in the market.
So let's back up a little bit. Growing up in Turkey, what got you fascinated in this specific part of the economy and business and the industry?
In terms of research or operations in general?
Both.
Let me start with operations. It's funny how I ended up in operations, actually. So in Turkey, nobody goes to business school for undergrad. It's not within our genes. For MBA, it's becoming more and more popular since I left, but undergrad was something else. So the nearest thing I could study to business was industrial engineering, which is exactly what operations do.
And you have a PhD in that as well.
Exactly. So I continued doing industrial engineering. And then, I mean, obviously, as you grow, you learn new things. And I got into different things after that. And in terms of healthcare, my primary motivation was I figured out they needed help in that industry more than any other industry, because if you're talking about supply chain, if you're talking about gig economy, they're big companies with big pockets that can finance these research.
When did you figure that out? When did you figure out that it was healthcare?
This was back in 2010, early 2010s. I was at University of Rochester at the time, and the medical school was right across the street.
Convenient. Just like with Rice, the medical center is right across the street.
Exactly. And there we also had healthcare programs where we used to teach people from all kinds of roles in the medical school, well, from the hospital, basically. And talking to them, I figured, look, there's a lot going on here. The first interesting question that I came across was I was teaching an EMBA class, just like that you took, one that you took within our program. Medical doctor from the emergency room was taking that course, came to me and pretty much said what I was teaching is useless in the emergency department. And
how did that feel?
I was like, really? And the specific thing I was teaching was very basic capacity calculations, where in order to find the capacity of a resource or a doctor or a bed in the emergency room,
it's an equation.
All you need to figure out is how long it takes to process a job, a patient, whatever it is. And she was like, look, the way we work, we typically take care of 5-6 patients at the same time. We're just walking around in the bays. If you've ever been to an emergency department, they have these bays inside where they have beds. And then while I'm walking to one patient, I get a call from about the other patient because I probably asked for an x-ray or I asked for a consultation with a specialist. And then I go back to my desk. I enter my notes about another patient. So you're telling me to figure out how long it takes to take care of a single patient.
Yeah.
I don't know. And I don't think you can figure that out.
Well, it also depends on the patient and depends on their level of, need.
And even that, I mean, I think the complexity here is unlike many other operations. For example, let's say you're checking out at a supermarket. What happens is as soon as the cashier starts scanning your items, I know when your service started. And you pay and walk away from there, I know when your service ended.
Yes.
In terms of the cashier. In the emergency room, you never know. The cashier talking to you goes back to another checkout, talks to another customer, comes back. For example, they're walking. Whose service time that is? Like, how do we take that into account? Then gets a call about another item. So it's so complicated. It's very difficult to figure out how much time goes into a specific page.
Yeah, lots of variables for sure.
Lots of things to figure out. So even the basic theory fails. And that's how it started. I spent about, I don't know how much in total, but it took me about 6 months to shadow every single relevant decision maker in the emergency department. I saw a lot of gruesome things that reminded me one more time why I didn't go to medical school. But it was eye-opening. Yeah. Let's just put it that way.
And is that what made you recognize that this is a really significant need, that you could, sort of change the direction of healthcare?
I started with very humble beginnings, as in, let's say I was like, okay, how do we fix emergency departments?
Because nobody wants to go to the emergency department because that's the last place you want to go. Because you could be there for 15,000 hours.
And unfortunately.
And that's why it's just very inefficient.
Exactly. And what happened was I worked with them for a few years, and there's a lot of research on improving the efficiencies in the emergency department in terms of reducing the time you spend there, spent waiting, spent being treated. And we would implement a lot of these things. And I was working, because it's a medical school as well, they were very research oriented. So they would implement a lot of ideas. They would look at other emergency departments to come up with new ideas. And a lot of things that I would say, I would recommend, like, why don't we do this? It's like, the hospital will never agree to do that. And I'll give you one example. I mean, emergency departments, once you get in, actually, it's, although it looks very complicated, there are very simple reasons why you spend that much time. One of the main reasons why people spend a lot of time in the emergency department is because there are not enough beds. And the reason why there are enough beds is the emergency department, the main goal of the emergency department is not to treat you, it's to stabilize you. Or, if it's minor, say, look, it's okay, you can go home. So once they stabilize you, if your condition is serious, you have to be admitted to the hospital. So basically, they take you upstairs from the emergency room. Usually, the emergency room is in the ground floor. And what happens is a lot of patients get stuck in that process. So you're in the emergency room, they took care of you, they said, admit this patient, they signed the papers, and you spend, let's say, 12 hours in an emergency room bed for them to take you upstairs. And obviously, when you take that bed, they can't put a new patient there. And then it backs up everybody else.
The bottleneck.
That's one of who's the bottleneck? I mean, even that is not clear, right? I mean, there's a bigger problem. It's not just you go to the emergency room, fix it, everything will be fine. It's not the inefficiency in the emergency department, it's inefficiency in the system. And from there on, I start looking at bigger and bigger questions, which took me to my research as in the today.
So tell me about your research. What were the bigger questions? This is exciting because I want to know how it's all going to be fixed and magnificent. And, this is really, it's because healthcare is it's crucial and it's really integral for all parts of your society.
Absolutely.
Not only the economy, but for a healthy society and for everything else. And in order to be, the leader of the free world, you need a healthy society. So yes, I'm very excited to hear about your research.
Absolutely. I mean, first of all, this is one of these things where there's not going to be a clear-cut solution because there are a lot of political issues. And obviously, people from different parts of society have different opinions about different things. So
and
there's
lobbies
never going to be
and things like that.
Everything. Not even lobbies. I mean, just some philosophical questions. For example, Medicare, right? Medicare is something that we provide. Basically, we more or less working people finance elderly so they get almost free healthcare in the US. That's not cheap.
No.
And is that something we should provide? Or is this something we should ask people to save just like they do for their retirement? So there are a lot of philosophical questions in there.
Like universal health care. I was reading an interview with you where you said, I don't understand why people don't, like when people are against universal health care, that it doesn't make any sort of logical sense.
I mean, as I said, there are many, many different moving parts into it. Let me try to demonstrate the problem first. Is there anybody who doesn't believe we have the best medical schools, best technology, best education in the world? If not the best, probably top 3 for sure.
No, of course.
Yet, overall, what we produce from that system is not even top 10. In OECD countries, we're in the bottom in a lot of quality measures. And definitely not in cost. In terms of cost, I don't remember the exact number, but we are quite high from the second worst country.
Wow.
Performing quite worst. So how do you come up with the best components, but the worst outcome? Not the worst, but pretty much pretty
not
bad
a good one.
outcome. You're right.
You're the bottom.
So that actually answers your question. So it's not that, we don't have a system that doesn't have the potential. It's like you spend all the money. I don't know if you follow sports. Just imagine you run an NBA team. You hire the best players in every position, but you can't even make the playoffs. Another example I would give you is I guess this is easier to kind of demonstrate. You go to Central Market, you buy the best ingredients, but unless you have the right recipe, whatever you cook, obviously, will not taste the way.
Well, and there's user error. I'm a horrible cook, so there's a lot of user error as well. You can have the best ingredients and the right recipe and still have a mess and it tastes horrible.
I guess what happened is over time, because the way the economy and, they restructured the US economy, we did not get the right recipe. And more, again, for those of you who's thought about these issues, you can think about project management. So the project here is every person is a project in terms of their health, managing their health. Yet we don't have a project manager. So everybody takes care of one part of the project, but they never coordinate really. There's no coordination. It's expected from the patient to kind of coordinate the care. But imagine, I'll give you another example. The warranty on my car just expired and I was looking into extending the warranty. And when you look at the warranty terms, there are like 1,000 exceptions.
Yeah.
It's impossible for me to figure out even even for a car to understand, what it includes and what it excludes, let alone something that involves health. So my research in general, what I try to answer is, okay, we have this best system. How do we coordinate it better? How do we make sure they're connected better? And usually you do that, at least, from a business point of view, looking at it as a business is with financial incentives. So I try to figure out the best incentives to give so that everybody acts like they're doing the best for the patient.
So what are those incentives?
Many. It's not me who came up with the idea. Actually, CMS, Center for Medicare and Medicaid, who runs Medicare and manages most of Medicaid, at least the federal side, they come up with these programs, and that's where the ideas came from. For example, one of the things we figured out with the emergency departments, the reason why you wait so much, as I said, among the other things, hospitals weren't investing to reduce waiting times. And the reason for that is if you operate at 100% utilization, obviously you're going to take care of you're going to produce the most from your resources, but obviously that's going to cause a lot of people waiting. Just imagine you're driving during rush hour. And why don't we pay them to reduce waiting time? That was our idea. So let's say we're in Houston, we have 4 trauma centers. We look at their average wait times during the busiest time, let's say on Mondays from 9 to 2 p.m. And then we rank the hospital, and whoever manages to reduce the wait times beyond the average performance in Houston will reward them. And whoever manages worse than the average, we're going to penalize them. And it could be a zero-sum game. We could just cut off some of the payments they get and then make those hospitals responsible for the waiting time or invest that money to reduce wait times. And eventually you can analyze the system in different ways and show that, yes, now they have the incentive to reduce wait times.
So the healthcare sector has generally lagged behind in adopting operations innovations, seen in other industries. Why?
Multiple reasons. The primary reason was lack of sufficient data. Because if you look at if you talk to anybody in healthcare, you would hear stories like, 20 years ago, we did everything handwritten, like all the very important details. Manufacturing had moved a lot faster, primarily because of competition from overseas, especially coming from car manufacturers from Japan. US healthcare was very slow. And again, I'm not going to go into a political discussion, but that's one of the best things that Obamacare did. There's a history behind it, but Obamacare was the legislation that forced it. It basically said, unless you implement electronic medical record system, which is computerized data records,
which we all have now. You can get on your phone and you can get on My Chart and you can see your entire family, and It's fabulous.
And unfortunately, they had to twist hospitals' arm in a way to implement those systems. And now we have the data.
Why? Is it just because it changed? You would think that it would be more streamlined and more, all of the things that
it's status quo, because there's no competition. There's no reason why you would do it.
No incentive.
No incentive. Business as usual. Why would you? And another thing with hospitals and healthcare systems, usually, because, again, it's looking at the big picture, there's no direct competition.
Right.
How many times did you pick a doctor because of the price and quality even?
Right.
The only thing we do really, if it's a really significant surgery or something, we ask around friends, this and that. But even that is limited because your insurance might not cover. So there's zero competition, pretty much. And one of these things we try to do with the incentives is create this competition one way or another, at least in a sensible way. But anyway, that was reason one. And reason two is because it's a very technical field. Most of the upper management, C-levels and all that, come from medical backgrounds rather than business. And it's a taboo to talk about healthcare as business. Again, I'm not holding it against them, but if you compare to any other industry, even tech, for example, look at Google.
Yeah.
One of the first things Google did, as soon as they figured out, they're going to grow, they actually hired a CEO that had nothing to do with tech, doesn't come from a tech background. And they managed to grow the company to the levels now. I've never seen it in any hospital system, any healthcare system. It's always an MD leading it because medical care or medical needs usually take the lead. I'm not saying it's a bad thing or a worse thing, but in terms of business not playing as much of a bigger role.
Well, maybe that's why my MBA class had so many MDs in it, because a
There
lot
you
of
go.
MDs go back and they get their business degree because they recognize that need and that you really need to have that background and that understanding in
Absolutely.
order to not only be a good doctor, but in order for your business to thrive.
I mean, it's another thing that's changing, but at least back in the day, they had almost zero business education, even basic corporate account. Like, I don't think they've ever seen finding present values and future values in medical
Yeah.
school, even that, which, is like business 99 to understand the very basics.
So, what do you think are the greatest opportunities for innovation in the healthcare delivery system over the next 5 to 10 years? Because we have gone digital, right? And now you've got AI. Yeah, I'd love to hear your thoughts on how you think AI is going to propel us forward into the next, generation and generations ahead. And especially being in Houston, because it is, Rice is one of the best business schools in the country. And, the Houston Medical Center is where everybody from around the globe comes. So, what do you see the future holding for this specific kind of work and efficiency?
Yeah, I mean, talking about AI, it's absolutely, I mean, it's changing certain things. When you talk about healthcare, there are many different aspects to talk about. And when I think about AI, it's not the business side that's going to change first. It's going to change the medical delivery side of it, just like any other business. For us, for example, it makes a lot of things a lot easier to do. Writing an email, sometimes checking or editing a document, and so on and so forth. And just like that, I think the first step would be when you're making medical decisions, it will increase I shouldn't say accuracy, but it will increase at least the efficiency of doctors making that decision, because now you have a second opinion right there at your fingertips. I think that's what it's going to change first. I'm not sure how big of a role it's going to play in terms of increasing efficiency overall in the system, because I think our problem's not as complicated as
Curing cancer?
exactly. Exactly. I guess that's the best way to put it. In terms of the problems we have in the healthcare system, you don't really need an AI. You just need a bunch of people come together and kind of arrive at an agreement about what we should do with it.
Do you see that happening in the next 5 to 10 years?
We're getting there. I mean, at the end of the day, I'm a scientist, right? My role, I believe, is to provide scientific evidence that there's a better way of doing things. And eventually people seeing that there's enough scientific evidence that we should change things. Is it going to happen anytime soon? I don't know what's going to happen. Either we're going to get smarter about doing things, or the finances will force us. For example, it's not clear if Medicare will survive the financial pressures that it has. But what people don't understand is the way we run Medicare is the way we run Medicare. We can change the way we run it. So it's going to come to a point, if we don't change it, that its financial burden will be so much, people will refuse to pay that kind of money.
Right.
And then you will have to change the system. And I think at that point, it will force everybody to rethink the way we run the healthcare systems here.
And, the prices are just astronomical. Even just getting like a filling filled in your child's tooth. You kind of look at these insurance bills and you're like, what on earth is going on? And is that part of competition as well? I'm assuming that it is.
Absolutely. Absolutely.
Yeah.
I'll give you an example from our recent research. So this is one of the things that it's been around for a while, but it just become more competitive recently, and it start making more sense. There are many reasons why, but it's called Medicare Advantage. So when you become a Medicare beneficiary eligible, you can actually, instead of taking the government plan, which pays for fees, and whenever you go to a doctor, which pays the bills, you can actually sign up for an insurance policy just like you do with your employer. And any insurance company within certain limits can offer insurance policies within this market.
Hmm.
And that creates that competition, because if I'm an insurance company that find a more efficient way to treat these patients, obviously, and there's a fixed payment for each patient, I'm going to generate positive margins.
You need more patients. That's a way to do it.
Exactly. I'll attract more patients. So we are finding things that's going to help. And it's going to play, one of the things that's one of the reasons why I said universal care. Why don't we extend it to everybody? Why do we have employer-sponsored insurance? Makes no sense to me. Because it makes sense to pool the risks in a bigger pool than just an employer. Why don't we pool those risks, give people options, and they choose things that they think
A national healthcare
at least statewide, even citywide. I mean, it would make more sense than these silos.
Countywide. Yeah.
Well,
We have something countywide, right? Harris County Health System.
Oh, that's Medicaid. That's related to Medicaid for lower income. The same thing. A lot of states have similar system for their Medicaid beneficiaries. So why don't we do that? And that way, you force companies to compete with each other. The problem with prices in hospitals is they're priced as if a sheikh will walk in and pay those prices. So that's how real they are.
It's crazy.
And then, next time you get a bill, look at what the insurance paid. It's probably
I do. I look at every single one.
It makes no sense to me anymore, so I don't, but.
Well, and imagine having a baby, because I've had two, and I was on two different insurance plans, and I put them side by side and looked, and one bill was a couple of $100 to have one, same kind of birth, a couple $100. The next one was like thousands of dollars, and I was like, I didn't get anything extra. I was actually out of the hospital.
Again, that's unfortunately the result of siloed insurance and siloed payment systems and all that. And we see that all over. Because the prices are so opaque, and insurance companies, if you look at actually the contracts between insurance companies and healthcare providers, it's hundreds of pages with all the exceptions. How do you sit down and negotiate these prices for all the possible conditions your beneficiaries will meet?
Right.
All the possible treatments. It's impossible. So expecting this at the micro level, as I said, to be very efficient is just dreaming.
And also thinking about the micro level in terms of patient care, improving the compassionate experience for patients, because these are people, right? These are human beings that live in the greatest country in the world that can't afford healthcare. And it's just mind-boggling to me that when you start thinking about the people that it affects, the children and the parents and the grandparents and everybody else, I think that sometimes we miss the forest through the trees, right?
We do and we don't. Depends. You want to live in a capitalist country and then talk about compassionate care. They just don't agree with each other as much as you think you would, because then we start talking about compassionate care in a car mechanic. Then we talk about compassionate care in whatever you can imagine.
But a car mechanic isn't a person.
No. Again, it's all about competition, right? If that's what you're looking for, you'll find a car mechanic or a hairdresser or whatever will give you that treatment. In healthcare, because the prices are not what you pay, or you don't get to choose, that makes it very difficult. But good news is there are also initiatives that are taking that into account. Right now, there's a big program going on called value-based purchasing, again, from Medicare. And the good news is a lot of private insurance also adopt these initiatives from Medicare. One component of it is it rewards hospitals based on patient surveys. And patient surveys have questions such as, if they've taken good care of me, they were respectful and all that. I've gotten one of those questionnaires recently because I had a CT scan done, and it was pretty comprehensive. So it is moving there. At least we're finding ways to accommodate that into the system. And I'll give you an example just to give you an idea how bad it was before these initiatives. Back in the day, this is about 20 years ago, a hospital, let's say, God forbid, you had a surgery in a hospital. So the hospital gets paid from Medicare or from insurance. And private insurance obviously depends on how they apply, but let's talk about Medicare. And let's say they made a mistake, whatever it was. And within 20 days, you got readmitted to the hospital. And it was all their mistake. And you spend another 10 days in the hospital. Guess what? The hospital got paid again for the readmission. It was that bad. Now they're penalized. Now there's a system that penalizes them if their readmission rates are more than what it should be. So things are moving in the right direction in a lot of ways. But I think, again, it's going to take a while because this is a very different industry. And there are a lot of things we need to figure out. I'm hopeful in that regard.
I am too. Because as you age, you really want to move in the direction where it will be, you won't be a burden for your children, and that the healthcare system will take care of you. And That's what we want, is to continue to move forward. What are some of the things that you're working on? Can you share some
Yeah, of course.
additional research that you're working on with us?
Of course. I mean, actually, that's very related to what you just said. From a personal point of view, when people ask advice, you're working with healthcare, what would you recommend? I usually say, don't get sick, as a joke, but
no pressure. Don't get sick.
find a good family physician.
Yes.
That changes everything. And if you can afford it, there's something called concierge medicine where they only admit limited number of patients and they take care of a lot of
And you get their cell phone number and you can harass them at 3:00 in the morning.
I think it's called executive medicine as well. It goes by different names, but it came out first as concierge medicine. If you can afford it, it's a great thing, especially if you know nothing about healthcare and the healthcare system in the US.
Yeah.
Because there are a lot of things you can only learn by going to medical school and, spending some time in the system. And obviously your GP would know a lot more. And that's what we are researching now. How should you pay your GP in general, so that they actually not only take care of you when you need to see your GP, but in general, how do you incentivize them to coordinate everything else you need in the system? Because right now, the way they get paid predominantly is they only get paid when you visit them. But obviously, you want your GP to call your specialist when you have a surgery, to call the hospital after you get discharged to make sure you get your follow-up care. And these things are very difficult to track. You can't pay somebody just because they made a call for 5 minutes. How much will they really pay them? But we're trying to figure out how to pay the GP looking at the patient outcomes. So if you're a good GP, your patients shouldn't even go to the emergency room that much. Or when they get released from the hospital, they shouldn't be readmitted, and so on and so forth, as much as, somebody who's not doing that right. So we're trying to figure out how to pay the GPs in a fair way. And then this has to accommodate also the fact that every region has different patients, different socioeconomic backgrounds, different political backgrounds, everything that affects GP care. For example, if you drive 100 miles outside Houston, your GP will probably dealing with a lot more patients than if you're right there in Houston. How do you take that into account? So that's what we are researching now. And we're actually trying to get all the GP care data from Texas. There's a very nice database UTH keeps trying to figure out, by looking at what happened in the past, what can be changed and improve the system from a GP point of view. That's one of the things we're doing.
So tell me about some of your students and what you enjoy the most about teaching.
It's a very diverse student body, obviously. We get people with very strong backgrounds in operations, and we get people who have nothing, who have never, ever seen or think about operations. I want to believe that my course is an eye-opening experience for everybody, seeing the strategic role operations play. And I love the conversation I have. I mean, multiple times I have conversations with people who come from operations and telling me, oh, I've never thought about these issues this way. Or people coming with no background and saying, oh, I've never thought this was something that plays such an important role. It's a challenge because a lot of things in operations change just like anything else. For example, revenue management became a huge part of operations. So we're trying to incorporate some of that. Gig economy became a huge part of economy, and their operations are quite different. It's always keeping you on your toes. I mean, it's both keeping these conversations relevant, the theory relevant, and applying in different settings. I think that's what I enjoy about it. I mean, I learn every year when I read, go over my slides and refresh what I include in the course.
So you've taught at a couple of different places in a couple of different countries. What do you like the most about being at Rice? Other than being right by the medical center, which is a given.
No, that's a great opportunity for myself, for being able to find people that I can talk about my research who actually do that on a daily basis. Within a year or two after I joined, I got a bunch of calls from friends, or, people that I know indirectly. Their kids were about to go to college and they would call me about Rice. And unfortunately, I don't interact with undergraduates.
Can you write a letter? Was that the way the conversation went?
No, it was mostly like, what is it like there? What's the student life? I said, unfortunately, I don't teach undergrads and I don't interact with them much. I wish I did more. But from what I see compared to other schools, they take care of their students here in every possible aspect. And I can see how, being a smaller business school, especially compared to London Business School, it's very personal in that regard. So they really make sure, they try to help you as much as they could. And they try really hard. And even for faculty, I feel that being in a smaller business school, you get a more personal touch in that regard.
It's a very tight-knit community. And,
It is.
you can talk to your professors and they have time for you, even, when they're busy. And that's one of the things that really drew me to Rice was it wasn't, a big, like the other Texas business schools. It really has a personal, intimate feel. And it is growing. We have an undergraduate program now that is fantastic. So more people get to have that experience. But it's just something, it's a little bit of magic, because I've been to a couple of other business schools. I went somewhere else for undergrad, and it wasn't really like Rice.
I mean, I've been around for a while. I've been around a different school. I can confidently say that really differentiates here, that, whatever you need, they try to do their best to help you. And I'm very proud of being part of Rice as well in general. I mean, I feel lucky to have a job that I have. They are very open about supporting people's research.
Well, we're very, very lucky to have you as part of Rice Business. And it has really been a pleasure. Really appreciate your time to sit down and chat with me about what you have done and continue to do for Rice Business. And it's been such a pleasure, Professor. Thank you so much.
Thank you, Maya. Thanks for having me.
Thanks for listening. This has been I'll Have You Know, a production of Rice Business. You can find more information about our guests, hosts, and announcements on our website, business.rice.edu. Please subscribe and leave a rating wherever you find your favorite podcasts. We'd love to hear what you think. The hosts of I'll Have You Know are myself, Maya Pomroy, and Brian Jackson.